The African Health Information Exchange project is a consortium that was put together a couple of years ago when we had funding to bring together personal level health data for HIV and TB to try and better curate those data in the interest of program delivery. And we wanted to work towards a generic architecture that could be widely used. And so we formed a consortium called the African Health Information Exchange, which was partners who all had an interest in bringing together personal level health data. The formal start of the African Health Information Exchange was with a grant from the Bill and Melinda Gates Foundation at the beginning of 2017, which brought together the team that I was involved in that was working on the national software that's used in clinics around the country for monitoring HIV and TB, as well as the National Health Laboratory Service, who processed the entire country's public sector pathology specimens, as well as the group that work with the National Department on unique identifiers and patient registration, and that is the Centre for the Council for Scientific and Industrial Research, the CSIR, and then the Health NPO who work on interoperability, the GEMBI Health Systems. The last partner in the African Health Information Exchange was the National Department of Health, and who are responsible for stewarding both the HIV and TB information systems as well as patient registration, as well as the Western Cape Department of Health, where we were prototyping many of the tools that the AHIE consortium were working on. Institutionally, the intention was to develop a community of practice, one that was de-linked from any single institutional entity, so that people who had an interest in developing interoperability solutions or working on the technology of how to best leverage health information systems that had person level health data, so that those bodies could come together in a kind of a virtuous community of practice. In terms of the deliverables of the initial funding streams, the first was to work on strengthening an initiative that was already underway in the National Department of Health to roll out a unique identifier. And a unique health identifier is an important building block of any work with distributed health information systems with person-level health data, because it gives you the key on which to stitch data together. Sometimes there's a bit of a misnomer that a unique identifier or a perfect unique identifier is required. In fact, there's a lot that can be done in the absence of a single canonical unique identifier. However, the development and rolling out of this patient registration system nationally, called the Health Patient Registration System, by the National Department of Health, was a key game changer in terms of improving the quality of identifying data that could subsequently be used for linkage. The second component of the investment was to build out the patterns and methods of consolidating data within large government departments. The South African public healthcare system is fairly uniform across the provinces of South Africa, where the provincial health service providers and sometimes large municipalities provide person-level health services to people with HIV and TB. And in fact, the majority of people in the country rely on the public sector health services. And many of the data sources are in common across the country, such as the National Health Laboratory Services providing the pathology results. So the second objective of the AHIE consortium was to develop the patterns for data consolidation and integration, curation, common terminologies, and to find ways of processing those data that would best be able to support operations. Then the third objective was to work on very specific interoperability solutions that were standards-based. And there we wanted to develop interfaces that could be used by multiple systems in the future, that were open and standards compliant. And that was in line with the development in the National Health Information System space, where the country had published normative standards for interoperability. And this was an attempt to give expression to that through for HIV and TB. And then the fourth component was to mature some reference applications that could use the interoperability to access the consolidated data in the consolidated data environments. And those included the National HIV/TB register system. That was an offline system sitting in the majority of clinics in the country, in fact over 4,000 clinics, which we wanted to evolve to be able to interoperate with the consolidated data environment. It included a web-based patient viewer, which could consolidate all the information available for a single individual in a manner that approximates an electronic health record, but long in advance of having true electronic medical records. So because of the availability of quite a large amount of person-level health data from administrative systems, such as the pathology services or pharmacy dispensing, it is possible to create a fairly rich person-level shared health record in the absence of an electronic medical record. And we wanted to provide a web-based accessible viewer for that. And then as the project evolved, we realized that it was possible to bolt onto that web-based viewer quite a lot of the functionality that was required for actually managing patients through electronic medical record type of functionality, where health workers would directly capture data into the system. And the advantage there was that because we already had access to many of the data points required for patient care, we could focus just on the additional data elements that hadn't already been consolidated. And so the single patient viewer, which was a reference application, became a much richer platform that included direct bidirectional engagement from practitioners, and we rebranded it the Open Integrated Health Platform, which is essentially a platform that includes a consolidation, the viewing, and the ability to interact with the patient data directly. And on top of that, we added quite a rich reporting layer. The main information assets that the Ahie project was able to leverage included the national system for HIV and TB patient management within facilities called TIER.net. TIER stands for 3 Interlinked Electronic Registers, which had its origins in an attempt to digitize the interlinked paper registers that the World Health Organization launched in the late 2000s, that sought to integrate TB, HIV, and the prevention of mother-to-child transmission services. So TIER.net was developed as an electronic expression of those linked registers, and was very much a register system initially, but became quite a rich platform for patient management, but remained an offline system with the opportunity for benefits from data integration. The second system that was quite widely leveraged was the National Health Laboratory Services corporate or centralized data. And South Africa is fairly unique in having one pathology service with, I think they have over 500 laboratories nationally that all contribute data into a single national data warehouse for pathology results. So bringing those data into the fold was another huge opportunity. And then the third area was the unique identifiers. So I've mentioned previously that the National Department of Health was rolling out the Health Patient Registration System, or HPRS, which was rapidly expanding the presence of a patient registration system with a unique identifier into almost every primary care site in the country. And the Western Cape province already had for 20 years progressively implemented a unique identifier on a very similar architectural principles, which was already pervasively used and provided the ability to develop systems long in advance of the maturity of the HPRS system. And then finally, within the Western Cape specifically, where the data consolidation was being prototyped, there were many other person-level health systems, including primary healthcare information systems, pharmacy systems, both direct dispensing systems from large facilities, as well as prepackaged medicines coming from a central dispensing unit. Some community systems, such as when pregnant women register for SMS messages, something called Mom Connect, community health worker systems. So we had about 20 different systems within the Western Cape that gave us the opportunity, using the unique identifier, to really explore some of the patterns that would work with multiple disparate systems that could be linked on a unique identifier. So the Provincial Health Data Centre within the Western Cape was an emergent phenomenon that really tracked the evolution of information systems from aggregate to individual. So the Western Cape gradually, over a period of 20 years, implemented a common hospital information system across 52 hospitals. Finally, in 2017, 18 years after they started, they got to the last hospital, and they expanded the unique identifier within that system to primary care, starting in 2007, and also got to full coverage around the same time as they got to full coverage for the hospitals. And that immediately created the opportunity to start working with patient data in an individuated way, compared to what had been the de facto standard and remains the standard in most of Africa, which is aggregate data systems in a kind of an action research type framework. So the District Health Information System, which is the standard way of managing health data, is based on very prudent delineation of indicators, which are collected through carefully designed registers and source documents at facility level. And those indicators are very prudently chosen because we're asking health professionals to go to extra effort to record them purely for monitoring purposes, normally without any benefit to the patient. And so that whole science of minimum data sets evolved around the District Health Information System, and that really has been the mainstay of health information systems. And the Provincial Health Data Centre was an explicit movement to augment that, not to replace it, but to augment it with leveraging person-level health data. Initially focusing on clinical data, but with the aspirations to ultimately also embrace financial and human resources data, which had their own parallel developments moving from aggregate to individuated. And that was very much an initiative of the Provincial Department of Health, supported by Ahie and other projects. The main outputs of the African Health Information Exchange are all, I'll describe them all as works in process, because they will all continue to be matured. The first is the Provincial Health Data Centre architecture, which is a set of processes for ingesting, processing, beneficiating data such that it is meaningful for managing HIV and TB. And that includes with it what we call the HIV and TB cascades and the various reporting artifacts that come off of those. So from all these 20 plus different data sources, we create meaning in terms of stitching together data across time for individuals and understanding exactly where they are in their care journey, and then leveraging that for the purposes of identifying who to care for, or for reporting on program metrics through various, or even alerting clinicians to specific events, sentinel events happening. And so the Provincial Health Data Centre database architecture is one of the outputs. The second set of outputs is probably the single patient, what we refer to as a single patient viewer, which is the web-based software platform that leverages data on an individual, but over time also evolved to become the portal through which one can access all the various reports, and also evolved into a workflow support platform where clinicians can actually capture data directly and be supported in things such as capturing data about a client in front of them, or doing an outbreak response for COVID-19, for example. The third is the interoperability tools. on the one hand, at the center is the Open HIM, the Open Health Information Mediator, which is already a well-known open source component, curated globally by GMB Health Systems, who are one of the partners on the Ahie project. And we developed some channels on the Open HIM using the HL7 Fire standard, which is just a more programmer-friendly standard for sharing health information that has gained traction in recent years. And so we elected to work with that standard and develop some channels that would be able to receive data from multiple different systems, representing the common data types that we would want to receive or serve from the center. And then we added to that a new interoperability component called the Open LIM, the Open Local Health Information Mediator, which we designed as a standalone component that could sit alongside a database or file-based information system that is offline and facility-based. And the reason for this is we wanted a solution that would allow places that had uncertain connectivity to leverage the interoperability when connectivity allowed, but not to be compromised when it didn't. So we designed it as a component that would run alongside of an offline system and give it hybrid functionality and communicate directly with the OpenHIM. Linked to that, we have a number of components which are probably useful independent of the data center or the any single piece of software. One is a voice calling solution which allows a call to be placed between two telephone lines without any reliance on sufficient connectivity for voice over internet communication. So all you need is a sufficient bandwidth to place to request the call, and then a voice bridge calls both parties using the phone numbers that are stored in the system for the provider as well as the patient, and patches them together, and has full visibility and logging so that it's unlikely to be abused for non-professional purposes. And that has proved to be a useful way of enabling people to work from home and not to incur personal costs, and to liberate non-government organizations from having to worry about providing airtime or costs to cover individual phones. Another component that we hope to package as a self-standing software component is the dynamic forms engine that allows for clinicians to interact with the platform, where we can dynamically specify based on context what fields to prompt for, or which fields are available, and we feel that that's a software component that could be used in other contexts. We have a third aspirational self-standing component, which is to provide an instructable for hooking and a device onto the platform. A device or a service, a patient, and the center could all interoperate with each other, so that somebody in front of a vending machine could be authenticated to receive a product from the machine, and the machine could be instructed to dispense to that person, and that would just be a prototype for how any external service could integrate with the combined environment. One of the key differentiators of the Ahie approach from traditional approaches is the fact that we are relying very heavily on administrative data. It's still clinical data, but it's collected as a byproduct of administrative systems, and stitching it together to create a patient-centric view, which has the potential to get to maturity a lot quicker than monolithic electronic medical record systems, which require huge infrastructural dependencies to get to the level of coverage required. to make sure that you know where every single person is in the care continuum at every point in time. So this sounds very crude, but and in fact it's often a comment I make when approached, as we often are, by people offering analytic solutions. The analytic challenge here is very straightforward. It's actually a binary predictive model. Either a person is in care or they're not in care. If they're not in care, they're not doing well. And knowing whether they're in care or not is actually the complicated component, because of the very disparate systems and being able to stitch them together. And that really is where the smarts is required on the data processing side rather than the analytic side. Not to say there aren't a lot of analytic questions that to be answered with the enriched data, but right up front, we just knowing if somebody has a condition, that they've accessed care. If they've accessed care, are they doing well or not? And have they remained in care? Those are the key systems, and that actually applies for almost every health condition. If you have TB, we know usually from the laboratory that's the most common form of diagnosis. Whether they've started treatment, we usually get those data from treatment register programs, but actually often people don't get into TB register because they've started treatment in the hospital and nobody recorded it. Whether they've been assessed for smear conversion, whether they've become non-infectious because the drugs are working, and whether they've completed treatment and we've confirmed that they've been cured by negative microbiology at the end of their treatment. It's an enduring pattern. It's a very straightforward set of metrics, but putting it together in a robust and reliable and timely way is what really transforms healthcare, because then you can identify exactly who needs to be followed up, who needs to be re-engaged, and who needs treatment intensification. I would say that the unique value of the Ahie approach is not relying on a single megalithic electronic medical record system for everything. We've seen those systems go wrong, both because of lack of coverage, delays in achieving that coverage, supply chain issues with large IT systems, especially with weak healthcare systems, whereas an interoperability approach that tries to leverage whatever data is there and then iteratively improve it often stands much better chances of success. And in fact, often one can start using the data a lot sooner than waiting for maturity of a monolithic system. We don't anticipate that the Ahie is a time-limited project. Although initial funding came from a particular funder, we've actually supplemented the activities from a range of different funding sources, and government themselves have invested quite heavily in maturing some of the components. And we would like to continue the African Health Information Exchange as a civil society clearinghouse or a grouping of people who are working technically on various aspects of interoperability within African healthcare, public sector healthcare settings. So we definitely see a value and a role for a structure that brings together people with a technical focus, working on these items that are not constrained by a particular funder or a particular government. So one of the unexpected initiatives was when COVID-19 became a healthcare crisis in 2020. And because the Provincial Health Data Centre was in place and the single patient viewer was in place, and there was a need to very rapidly consolidate data from a range of different sources. Most importantly, we had to onboard private healthcare data into a single environment with the public healthcare data, because this was a notifiable medical condition with statutory requirements for reporting to government. Having the data center with all the patterns that we had developed for integrating and ingesting data, and having the people, and I have to stress that the most important component of Ahie is demonstrating the value of people with the right data competence within government. Having those people in place who could rapidly adapt to this new challenge enabled us to create an end-to-end information system to integrate the various laboratory hospitalization mortality data into a COVID-19 data system, to be able to answer research questions around COVID-19 in an information-free zone, such as what the impact of HIV and TB were on severe COVID presentations and COVID-associated mortality. And then to be able to create an outbreak workflow to support the track and trace, which was not a separate system that was completely delinked from the data we already had, but was able to leverage the information we already held about people from the other healthcare contacts, and to rapidly integrate across multiple different systems. So we could hand off to a call center and hand off data to them and integrate their findings back into the consolidated environment. We could integrate data from the national track and trace system, which SMS'd people their results and engaged them in bidirectional cell phone-based contact with the National Department of Health, and we could integrate those data into our information system. So having evolved the single patient viewer into more of a health platform, the integrated health platform, we would like to see it be fit for purpose for all operations within a facility. And some of the things that are missing are things like a robust appointment system. So we'd like to make that available. We would like it to function as a standalone client registry, so that if it was used in a context that wasn't bolting it onto an existing client registry, such as the health patient registration system in South Africa, it could actually function as a client registry. Without the need for a separate patient master index or unique health identifier. So it could actually issue the health identifier itself. We really want to evolve the reporting to take advantage of even more reporting modalities. I haven't focused much on the reporting, but one of the key design considerations in the reporting was not to be locked into any reporting platform. So the platform at the moment integrates with the corporate capabilities of government. So where we were prototyping the Microsoft reporting tools were available, the tools that go with the SQL Server as well as the Power BI reporting platform, and we created ways of directly integrating and authenticating against those platforms. But some of the areas that we really want to enhance as well are some of the open source technologies. There's a lot more skill and capability coming through from academic programs in the use of Python and R and other other analytic platforms. And we want to find a way to seamlessly leverage whatever skills, whatever capabilities people come to us with into a consolidated and seamless reporting environment. As I said earlier, skilled people are the biggest asset, and we want to work to people's strengths. And so if we do get people with particular technology skills, we want to find more ways of integrating them into the reporting framework. The Ahie has really worked on maturing products to a minimum viable product status in terms of release. So we will be sharing the consolidated architecture, the web-based platform, the OpenHIM components through a website, and under open source licensing. And for any other artifacts that we create, we'll continue to share in the same way.